Well, hi, great to be here. And hopefully I can enthuse you with what is going to be a major game changer for the treatment of hepatitis C. And I must say, I'm delighted to have the Waiheke guys on, Margaret and Mike Karatai and Rebecca Potts. Almost 20 years ago, we did the education program for hepatitis C in Waiheke. And also in a couple of the People Centre downtown and Greater Medical Centre. One of Bridget's colleagues, Janice and I, were setting up a test and treat program back then, and that was using the ghastly old treatment of pegylated interferon. And I take my hat off to the guys in Waiheke and the guys at the People Centre who managed to get people in and treat people and get people through and cure them. But that was hard work, and not everyone was cured, as we know. So I'm really going to tell you about a lot's happened in 20 years, thank goodness. And now we have a treatment which really makes treating hepatitis C like treating a sexually transmitted disease. It's short-term treatment, cure, discharge. So hepatitis is still a huge problem. And WHO has got very interested in hepatitis over the last couple of years because we've done so well in fixing other infectious diseases around the world. TB, HIV, and malaria have all declined in terms of disease burden or people dying from those, whilst hepatitis C continues to climb. And last year, almost 1.5 million people died of either Hep C or Hep B. If you look at what we've achieved in HIV in this country, it's been remarkable, really. The mortality, when I was the AIDS registrar, because it was all AIDS, back in the late 1980s, the infectious diseases ward, absolutely full of poor young people dying from Kaposi's and Toxo and pneumocystis, and about 80 people a year died. And now, last year, I think one person died, the year before nobody died. This is a remarkable, I think, feat, not only of medicine, but of public health. We have wonderful HIV awareness, we have wonderful HIV advocacy in this country. We've learned a lot from Australia over that. We have good testing of the at-risk population, who are very aware of the risk of HIV. And as I said, we have treatment which isn't a cure, but long-term treatment now really returns life expectancy to normal with HIV infection. That's what we've done for HIV. At the same time, you can see what's happened with hepatitis C. That really reflects the poor awareness for hepatitis C in our population, low rates of testing. We have very low rates of diagnosis in this country of the infected population, and low rates of treatment uptake. And that reflected in some ways not only the underdiagnosis, but the fact that the interferon treatments were pretty ghastly, and overall they had cure rates of less than 50%. So you had a year of injecting a medicine which made you feel as though you had the flu, then at the end of that year, less than half of you were actually cured. As a result, the numbers of people dying from Hep C has risen really exponentially in this country, and this year it will be close to 200. So the mortality from Hep C is now more than 100-fold higher than HIV, and that's just happened over a short space of time. I think we need to learn from what we've achieved in HIV in this country and most countries in the world. This is the real hard data. We've combined, we share our data with the Australian liver transplant units because we share organs. But the numbers of people being transplanted for Hep C continues to rise. That should tail off thanks to these new treatments, but it's still rising by about 10% per year. More importantly, the number of people who we see at Auckland Hospital with liver cancer from Hep C is climbing fairly steadily at around 10% increments each year. We've now had over 520 people have Hep C related liver cancer, and just to remember, when you're diagnosed with liver cancer, your median survival now is still only 3 months. So it's fairly dramatic, I guess, marker of the burden of hepatitis C in this country. So how can we prevent these? Well, there are two ways we prevent Hep C infections and death. We know, I won't bore you with background, you know that Hep C is almost always now spread from people who inject drugs. We call them PWIDs for short. People who inject drugs are the source of hepatitis C in this country. A few blood transfusion associated Hep Cs or factor VIII in haemophilia, they've all been picked up, they've all been treated, or in the case of the elderly transfusion recipient, they've probably died. So all of the burden of hepatitis C is spread through injecting granules. And therefore, one of the important things we have to remember is stopping treatment through harm reduction. And harm reduction still is important, and today marks a very special day. Does anyone know what today is? David can tell us. So today is the 30th anniversary of needle exchange in New Zealand, of introducing needle exchanges. And so we were one of the first countries in the world to introduce needle exchanges as a way to stop spread of bloodborne viral infections in people who inject drugs, from the first countries in the world, even before Australia. And it's a real feat, and as a result of that, New Zealand has the lowest rate of HIV infection in people who inject drugs in the world, and that's because of the access to free needles or one-for-one needles. But the other way, of course, to prevent deaths is antiviral therapy, and you can actually prevent infections in patients if you treat them. But if you treat people, you prevent them from progressing to cirrhosis. If they ever have cirrhosis, you prevent them from dying because they regress with successful treatment if the treatment works. The World Health Organization, the reason we're here today, I think, is largely because our government signed up to the World Health Organization's targets in 2015. And that was a 90% reduction in incidence of that's both Hep B and Hep C, and a 65% reduction in deaths in Hep B and Hep C by 2030. And we're one of the 194 countries around the world who have said to WHO that we will achieve those goals. And that, I think, has driven a lot of what's currently happening in the sector. And you'll hear a lot more in the next 3 months about plans to improve awareness and testing. Okay, well, who's going to achieve those targets? There are 12 countries who are on track to achieve Hep C elimination from their countries by 2030. And they're shown in green. And there are 12 countries, and the biggest one, I think the one which is going to do it first, is going to be Australia. And they've done that based on a lot of advocacy which they have from the HIV days by an organisation called ASHM, you may have heard of. But there are many other countries in the world, such as Georgia, believe it or not, Egypt, Scotland hasn't made it, but France and Germany have. Some of these countries, drugs are provided free by the manufacturers, such as Georgia and Iceland. The other countries, the government's provided free for everyone. So how do you pick out these 12 countries as the other ones who are going to achieve elimination? Well, they have all of this in common. They have no restriction to antiviral therapy. Remember, in this country at the moment, we're restricted to genotype 1 only, which is only half our patients. So half of our patients have genotypes where we don't have funded treatment. You need to have treatment without restriction, and that's coming. You need to be treating at least 7% of your population, infected population per year. And we think that equals about 3,500 people we need to be treating per year in this country if we're going to eliminate Hep C by 2030. You need to have harm reduction programs. We have that, as do those 12 countries I showed you. We need to have a national screening program and registry. Now, this is very controversial, and we've been speaking to the Ministry about this. We need a registry for hepatitis C compulsory notifications, anonymised. So people can be tested, their results are sent from lab tests, a community lab, to a government-held registry, and then they're linked with treatment. Because remember, I'll show you treatment, you get tested, you're positive, 8 weeks of treatment, you're cured for life. Very simple. And if you do that, you actually stop transmitting the virus. And you need to expand treatment out of the silos in the hospitals. And that is one thing which has been learnt, and all of those 12 countries have pushed primary care prescribing. There's still most countries in the world, they do not allow primary care prescribing, but these 12 countries do. Can we reach these targets? This has happened. So in 2016 in July, the government funded this Vicaripac. And some of you may have used Vicaripac. It is quite a complicated treatment to use in primary care, but it is very effective. It's about a 96% cure rate. And because of that, because it's all oral, the numbers of people starting treatment, these are all people getting interferon, the injection, was going down, down, down. As soon as the oral treatment was made available, the treatment rate went up by 2,000%, 20 times. So remember that's limited to genotype 1. And I won't go into some details, but we've done some modelling that shows if you limit treatment to genotype 1, the red is what we'll achieve. We'll reduce the projected numbers of infections, we'll reduce the increasing numbers of liver cancer. So grey is a terrible colour. Green, I think it is. Green is what happens if we do nothing, nothing. With Bacteriopac, the red, so it's come down a wee bit. We've had some impact, but by limiting your treatment to genotype 1, you're never going to reduce the disease burden. You're just going to sort of attenuate the growth. You need to have, but if you have pan-genotypic treatment, now and that's shown in the light green, the modelling shows that you'll rapidly reduce the numbers of people dying from Hep C, people who get liver failure, these are people who get transplanted, people who get liver cancer, and you'll really start to eradicate hepatitis C infection as an infection found in the community. So as soon as we have pan-genotypic treatment, we should be able to start eradicating hepatitis C. And you'll avert 2,300 deaths even within the next 15 years just by having pan-genotypic treatment. That alone won't work. These are the numbers of people being treated per month since Bacteriopac became funded. You can see there's a huge increase, as I told you, and then things started to slow down and started to decrease. The one thing which we should be proud of is that we have a very high rate of, despite Bacteriopac not being that easy, remember it's several tablets a day, twice daily, 12 weeks. They had to take a drug called ribavirin, which would make people feel tired and anemic. But despite that, almost half the patients now who are being treated in primary care. So it's been really, really successful in terms of moving treatment out of the hospitals. See, what was happening here was that they were just emptying the silos of people on waiting lists in the hospitals, and they weren't encouraging general practitioners to get involved in treatment. So I think we lost a golden opportunity back then, which we're not going to lose with Maverick, the next treatment. But even so, now about 30 to 50% of all people starting treatment are being treated by GPs, not in the hospital. But overall, the numbers are going down, and that reflects the fact that we're running out of people to treat, because we haven't increased diagnosis at the same time. So we need to find the undiagnosed. Now, people say, well, what do you mean? How many people are undiagnosed? We think there are 50,000 people infected in this country. And we think there's 50,000 infected based on quite a few assumptions. The rate, if we assume the prevalence of Hep C is the same in New Zealand as it is across the ditch in Australia, at 1.1%, that would give us 50,000 people. We've also got some data from lab tests. And lab tests, the community labs, have diagnosed around 28,000 antibody positive people. We think that's about half. The diagnosis rate is about 50% of that 50,000. So how do you find the undiagnosed? There are three ways that you can look at testing. Targeted testing is when you test people who you think has risk factors for Hep C transmission. Now, risk factors for Hep C transmission are really those related to injecting drug use. And it's not injecting drug use now. It could be a whole generation away from using at university or using at high school. I won't show you the trends, but most people who get infected with Hep C get infected between the age of 17 and 25. And that's when they start using, and that's when they tend to, by default, they share gear, they share works from somebody who's infected. Also, most people who start using at the age of 17 actually stop using. It's a bit of a different substance addiction than alcohol, for example, where most people we see in clinic haven't used for 20 or 30 years. Many of them have led a completely normal life, have gone to university, have families, work full time, but there was a period in their lives, usually in their late teens, where they had high risk behaviour and became infected with hepatitis C. So targeted testing, which is the approach we've used, and which is the approach Australia uses and the UK uses, means you really target people by raising awareness. Did you ever inject drugs? Go and get tested. Or you go to those centres where you know there are current injecting drug users attending, and those include places like the needle exchanges, community Auckland drug services. Also, there's some other high-risk areas in the community. Homeless people attending Calder Centre. Calder Centre has the medical centre at the City Mission has a very active hepatitis C treatment program, and Bridget will probably expand about that a bit later. So targeted testing is where you're really concentrating on those risk factors. The other risk factors we include tattoos. And we say tattoos, the risk, I think, of contracting hepatitis C through tattoos is real if you happen to use unclean, unsterile equipment from somebody who has hepatitis C. Don't clean the equipment, tattoo somebody without. Now that's a very uncommon event. It won't occur in a licensed parlour, and in fact it's really limited to tattooing in prisons. But prison itself is another risk factor. Prisons, depending on what part of the world you're in, people in prison have a much higher rate of Hep C than people in the community, and that's obviously because people who are arrested for drug-related crimes go to prison, and also people tend to transmit Hep C within the prison. In New Zealand, we don't know what the rate is. We think it's somewhere between 5 and 10%. Corrections are still doing their survey to try and get us this data. In Australia, the rate of hepatitis C active infection in the male prisons is between 20 and 30%, and female prisons between 40 and 60%. It's really, really high. We don't think it's quite as high here, but certainly it's higher than the general population. So that's a targeted testing approach. So this looks okay, but the problem is, as I think I mentioned to you, the vast majority of people who have Hep C out there in the community don't identify themselves as having that risk factor at the moment, and they don't want to admit they've had that risk factor in the past because of the stigmatisation associated with injecting drug use. And that's our biggest challenge, to somehow destigmatise the disease or get rid of the association with injecting drug use. And that's led to a really interesting campaign from Hazel Hill in Dunedin, which is the Butterfly campaign. And in fact, that's spreading around not just New Zealand, but Australia and other parts of the world, where you ask the question, do you feel old and tired? Everyone puts their hand up. What if it isn't just aging? What if we could fix it? Hep C causes fatigue. It goes away when you cure the Hep C. So that's a good incentive to go and get a test. I'll come back to this, why I think this is a good way. So that's targeted testing. First cohort testing is what they've done in America, based on there's so much heroin use during the Vietnam War, lots of drugs coming in from Indochina, and the whole Woodstock era in the 60s and 70s was a huge spike in certainly narcotic use in the United States. So they said there's a certain cohort, if you're born between 1945 and 1965, you were hanging out in Haight-Ashbury at the time, heroin was flowing in, and you caught Hep C. But in fact, they're wrong. And that you're probably aware there's an enormous narcotic epidemic at the moment in the United States, using mainly fentanyl, but other narcotics as well now. And the epidemic of injecting drug use is going on. And I think they're about to abandon this first cohort. This became a compulsory thing in primary care in the Eastern Seaboard states, that GPs all had to test everyone born in that age group. They're about to abandon that. The CDC wants to move to the third, which I think is the correct approach, which is universal testing. Every adult has one test. And this really is why I think Hazel's approach is so good. Because basically everyone can say, I feel a bit fatigued now and again. Go and get a test. You only need one test. If you're 40 or 50 years old, you're very unlikely to be actively injecting. If you're negative for good. Yep. Now, universal testing is only possible if we have a national registry, and there's a reason for that. Otherwise, you keep on repeating testing and it becomes very, very costly. And that's why there's a need for a national registry, both to reduce the cost of universal testing, but also to link people with treatment as soon as they get tested positive. Okay, improve linkage to care. That's the second thing we need. And improve linkage from care. We still have a big gap between people being diagnosed and linked to care. And Mike's going to talk a wee bit about the look back, the lab test look back program later on. We think there's probably between 15 and 20,000 people in New Zealand who have been diagnosed but have never been treated. And I think that reflects lots of things. One of the things was nobody wanted to have interferon. And the other thing, which used to be a really big disincentive, was nobody wanted to be referred to hospital where some guy's going to come and stick a needle in your side and do a liver biopsy. Of course, we don't do those anymore. We stopped doing those 5-6 years ago. No, probably longer than that, Bridget. Very long time. So we do FibroScan, which is absolutely safe. So a lot of people just said, when they found out they had Hep C, they had friends or peers who had been through the system, they said, no, I don't want to be treated.
Can I just ask one brief question?
Yeah, sure.
Patients ask, is it ever transmitted sexually?
There's a risk. It could be. It's a blood-to-blood viral infection. If there's any risk of blood admixture, potentially during menses, traumatic sex, MSM, traumatic, there's a potential risk. But the CDC do not recommend condoms in a monogamous relationship if one partner has Hep C. In fact, there have been long and very thorough follow-ups of large cohorts of people with Hep C, showing that in people with their monogamous relationship, no risk to their partner. And so we don't recommend screening partners unless it's for reassurance or there's some other risk factors. Yeah. So it's not like HIV or Hepatitis B. So one of the things we think to improve linkage to care is that testing and the treatment's done in the same place. So we want community-based testing and treatment. Treatment's safer. Primary care knows more about the person's comorbidities. This will become far less of a problem with the new treatment, but this is a huge issue with Vicarapac because of the drug-drug interactions with Vicarapac, which interfere with so many of our commonly prescribed cardiovascular medications, psychotropic medications, and other medications that you really have to know what other drugs the person's on. What the patients say to us is they hate coming to hospital. It's not only it's a cost of going to hospital. This is a huge problem in places like Auckland or Greymouth or places where you don't have hepatitis clinics. There may be some ways to reduce travel costs, which Mike will talk about later on, where there can be GP payments, certain DHBs, including the ones we're in, and the patient payments. And Mike will talk about this later. We think if you get GPs testing and treating and curing people, they will test more people. Because there's nothing quite like curing a patient. They're so grateful, they feel so much better. There's a lot of positive vibes. But the main reason for treating people in the community is to reduce stigmatisation. This is a huge issue, and when people are canvassed about why they're DNAing hospital clinics, the biggest reason is they feel stigmatised and discriminated against sitting in the clinics. And that may be valid, it may not be. But we need to move in. Now, finally, access to pan-genotypic treatment. So we're really here tonight to talk about the initiative for pushing even harder than before community-based treatment is treatment has become simple. Pan-genotypic treatments are where you treat everyone in your practice with the same treatment, regardless of their genotype, which you don't have to test anymore. And this is a drug, it's called Mavorite. It's all you need to know, so it's a single tablet which contains two different antivirals, molecules which block the hepatitis C. One is called a protease inhibitor, one is called an NS5A inhibitor, and they're combined in the same tablet. These are the last drugs ever to be developed for hepatitis C. So there's the Gilead cephalosporin treatments, and then there was the AbbVie Maverick treatments, and all the other companies have abandoned drug development. So there are only two pagentivic drugs available in the world, and this is the most advanced one. It's huge numbers of people have been treated in trials, and now huge numbers have been treated since it became approved by the FDA and the European Agency in August last year. So, it comes like this. It's 3 tablets a day, once a day, for 8 weeks for all of your patients. So they take it once a day, 8 weeks, no ribavirin, no other medicine. So it's 3 tablets in a blister pack. They pull out. Have you got examples here? I'm not sure. You push it out, you take it in the morning, and you do the same the next day for 8 weeks, and you stop. And it comes in a weekly carton, and the weekly cartons are put in the monthly cartons. Very, very simple. Lots of trials. Just to show you the cure rates are extraordinary. The overall cure rate in the clinical trials was 97%. It was 97% overall people cured with 8 weeks if they didn't have cirrhosis. And we're saying that people without cirrhosis are the people you treat in primary care. And that number is getting higher and higher. The numbers with cirrhosis are rapidly decreasing, which is a good thing. So 97% of people treated with Maverick achieved cure. Now of the remaining 3%, most of them stopped the treatment. They never got through the full course of treatment. If people actually take the 8 weeks of treatment, the failure rate is only 0.5%. So their failure rate is, you have a drug which is over 99% effective. But it's important that people continue to take the drug. And it doesn't matter, you put in all the things about what drugs they're on, how severe the scarring is, do they have HIV infection as well, are they African American, which has always been a negative predictor of interferon, are they obese, are they over the age of 65, are they male? All of these factors associated with poor response rates to interferon has no effect on this drug. It's 97 to 99% for everyone. So this is simple treatment. So what about, these are trials, what about the real world? Well, because this has become the #1 treatment across the world, it's replaced all other treatments. That's a leading prescribed treatment in Europe and North America. We already have quite a lot of data. And the cure rates, and this is a large German real world where they've got together GPs who are treating and got all their results. These are not clinical trials. So far they've data 96 patients, 93 patients were cured, the other 3 patients discontinued treatment for other reasons. They were chaotic, they went to jail, one person had a car accident. That should be 93. Of the 93 patients who completed treatment, all 93 were cured. So it looks as though the cure rates in the real world in your practice will be exactly the same as what I showed you in the clinical trials. It's a very effective treatment. The duration depends on the severity of the disease. And all we're saying here is your patients are going to be these top patients. Genotype 1 to 6, there's 6 types of Hep C. Most patients in New Zealand are 1 or 3. Now that we're curing all the ones, by Curapac, or a lot of them, genotype 3 has become the most common. Everyone gets the same, 8 weeks, 3 tablets once a day for 8 weeks. The cirrhotics should still be referred to the hospital because those cirrhotics need ongoing surveillance for liver cancer to make sure we pick up the cancer. We know we reduce the risk of liver cancer by curing patients, but they still have about a rate of about 1 to 2% per year. So we put them in intensive screening so we pick it up early and we can cure the cancers. So yours is really the top bar. So how many people actually are suitable for 8 weeks? This is some modelling data. At the moment, if we say there are 50,000 people living with hepatitis C, around 90, the people who are suitable for primary care are people who don't have cirrhosis, who haven't been treated with interferon before. Now that makes up at the moment 90% of all people living with Hep C in New Zealand. In Auckland, it's actually, I think it's going to be higher because we've had clinical trials for the last 5 years. where we've treated almost all our interferon experienced patients, so we have a much smaller blue area. We've been lucky enough to treat almost everyone with some of these new trials. But that's in 2015. We know that that is already falling because most of the cirrhotics are being targeted for treating early. And we expect that within a couple of years, it's going to be 98% of everyone living with Hep C in New Zealand are going to be suitable for treatment in primary care. They're not going to have cirrhosis and they would have never been treated before. And because the cure rates with this new Mavorite are over 99% if they take the tablets, this should rapidly wipe out hepatitis C as a public health problem. Just a bit, just say one thing. Are you talking about fiber scanning and APRI? Okay, I'll leave that to you. Okay, Vicarapac. For those of you who've used Vicarapac, you'll be aware that there are lots of drug-drug interactions. I've listed them here. The red ones are never take those tablets with Vicarapac. The orange ones are you can use them, but you have to reduce the dose and be cautious. So that's Vicarapac, and this is Mavorite. There are really only two drugs which are contraindicated, atazanavir and rifampicin. There are several you just have to be cautious with or you need to hold during treatment. So it's a much, much easier treatment to prescribe than the old Vicarapac. Much simpler. You don't need, Bridget will talk about tools where you can look for drug-drug interactions, but really the drug interactions with the new Mavorite are very predictable and avoidable.
Was that a torvastatin on the top?
Yes, a torvastatin. So we tend to say to people on any statin, just don't take the statin for 8 weeks.
Oh, okay.
Yep. With the Vicarapac, if you use that, it has a drug called ritonavir, so the drugs last around for a couple of weeks after you stop taking them. Mavorite has no ritonavir. So just stop that torvastatin the day you start the Mavorite. You can restart the torvastatin the day you stop the Mavorite. There's no overlap. It's very simple. So Mavorite ticks all the boxes. It has a really high cure rate. It's across all populations. I haven't shown you that data, but it doesnn't matter if you're old, young, male, female, cirrhotic, non-cirrhotic. It's very effective. 8 weeks. All genotypes, so we're going to get rid of genotyping, so you won't need to genotype people. Now, when Mavorite comes out, the biology labs are looking at stopping genotyping, because you won't need to do it. And the reason that's great is because it brings down the cost of testing. Soon, you won't even have to do an RNA test. There's a new test coming out called an antigen test, which will be able to be done on the community labs. So you just take a blood test off, it goes to the lab, they put it on the analyzer, that's the analyzer which does all the biochemistry. It reads out the antibody result, and if the antibody is positive, it automatically does an antigen test, and there's no need to send the bloods off to the hospital labs for RNA anymore. So that's probably about a year away with it. So Mavorite, no ribavirin, which has been a bugbear, I think, even after we got rid of interferon. Minimal drug-drug interactions. You don't need to monitor people. So people in primary care, 8 weeks treatment, there's no need to do any blood tests. They don't get anemic, they don't get any liver problems or kidney problems. You can just give the person 8 weeks of treatment and then bring them back to check that they're cured. I would say if you're concerned about the person's understanding of the treatment, or if you're concerned about their otherwise their compliance, it may be worthwhile bringing them back after 4 weeks. So give them 4 weeks supply, and then when they come back, give them the next 4 weeks. But Bridget will show you, we've done a study where we haven't done that. We've just given people the entire 8 week supply and seen them 12 weeks after treatment is finished to show that they're cured. So you don't need to monitor at all on this treatment. There's no need for resistance testing. This is very simple treatment to use. And it should improve treatment uptake. It's very simple treatment. Very simple for you to work up the patients. I mentioned that. There's really simple on-treatment management. And we do encourage trying to get people back to show that they're cured. In Australia, where they're treating 70% of the people in primary care, the GPs are saying, well, you know, we're treating people, but they're not coming back to check that they're cured, but we know that they pick up all their tablets. And on sort of, it's not herd immunity, but a similar thing, you can say that almost everyone will be cured. The people who are not cured tend to represent because they feel tired again. But we still encourage patients to come back to show that they're cured, even though there's a less than 1% chance of not being cured. Okay, so I'm going to hand over to Bridget, who's going to tell you how it works with Maverick. Yep.